Okay, I kind of went through that very quickly. So really, variability, the takeaway message is we want to see really good variability. If it's too little, then it's non-reassuring. If it's too much, then it's non-reassuring. A marked variability fetal heart rate means that a baby is stressed or something else is going on that we need to be concerned with if it does not resolve. So that's variability. Let's talk about accelerations now. We like to see accelerations. These are reassuring. They reflect a well-perfused fetus. And an acceleration is defined as a rise from the fetal heart rate baseline of increase of at least 15 beats per minute, lasting at least 15 seconds. And this is what we're looking for with the non-stress test, if you remember. So it usually occurs with fetal movement or during a vaginal exam. So if you see this fetal heart rate monitor and this fetal heart rate going like this, just these up and down movements, then that is usually when they're getting a vaginal exam during labor process. Okay, so the first kind of D cells that we're going to talk about are variable D cells. And these, you can see right here, are not reflective of anything in that uterine contraction pattern. So they're kind of random. And they are a sign of cord compression. It just is a restriction of that flow through the umbilical cord, usually pretty quick to resolve. No uniform appearance. They don't have anything to do with this contraction pattern. And how we resolve these is we're going to change the mom's position, which I think we talked about in lab pretty well. So early decelerations are a good thing as well. It shows that the fetal head is down, pressing against the mother's pelvis, and it's just vageling. So it's cutting off that fetal heart rate just for a minute. The baby vagels, drops its heart rate, and then returns to baseline at the end of the contraction. So you can see almost a uniform shape. So as the contraction pattern is coming up, the decel is happening at the same time, and then as the contraction is resolving, the fetal heart rate deceleration is resolving as well. It just is it follows along, and because it resolves along with the contraction, we know that there's no problem with the perfusion of the baby. There's no intervention that is required during that. It's usually a good sign that labor is progressing. And then there's the late deceleration. So these are non-reassuring patterns. They reflect something wrong with the utero-placental connection. So it's a sign of utero-placental insufficiency. So if you see the drop in the deceleration after, so you can see right here in the acme or the peak of the contraction, then the heart rate drops, and it takes much longer to recover after the uterine contraction has recovered. So I've got a bunch of slides here to show you kind of what the decels look like. So they can be, not as obvious like these ones right here, but you can tell these are dropping after every uterine contraction. So that's why we get baseline, and that's why we look at strips for a while, because we want to look at patterns. We want to look at see what's going on, not just in one incidence, but in many incidences. And then we can make a really good diagnosis of what is going on, whether or not we need to intervene, whether or not we need to do a C-section and get that baby out. So here's some decelerations. You see them dropping after the start. So it starts over here, and it drops about right here. Same with this one. So here's an early decel, going right along with the contraction, and that late decel. Recovery period takes much longer. Here's another slide to look at early, late, and variable decels, so you can get it into your head. Here's another good slide. Shows why it's happening. Looks what it looks like. And then this veal chop is something you should remember. So this is on the video that you watched in lab, if you recall. So the V is a variable decel, meaning cord compression. E, early decels, head compression. It's a good thing. Acceleration is okay. If they happen a lot, maybe you want to give some O2, but remember these are reassuring. Late decels, non-reassuring. Placental or utero-placental insufficiency, not a good sign. And then there's certain contraction patterns that we don't like to see either. These are hypertonic. Hypertonic contractions are when there's not that good period of relaxation, so it never fully relaxes. They are strong, painful, yet ineffective, so they're not doing anything to dilate that cervix. And a big contributing factor to that is maternal anxiety. So we're going to do things to get that mom's anxiety down. So rest, hydrate her, remember, because that's going to decrease the maternal oxytocin. And then we're going to give her either pain meds or sedate her. So let's interpret fetal heart rate patterns. There are 3 different categories, and we go through each category when we see something that's non-reassuring. So in category 1, this is a good fetal heart rate strip. So these are normal, reassuring, and everything looks good. These are things like moderate variability, accelerations like we talked about, early deceleration. So all 3 of these are good signs, normal, reassuring fetal heart rate patterns. Then if we see things that look like they could be a problem or they're non-reassuring, we will continue to monitor. If we see them in, they're things that you can see down here in category 3. If they keep going, if there's nothing, if we position changes, giving O2, things like that are not changing them, then they will either resolve into category 1 or they will become category 3. These are non-reassuring and these require intervention. We need to do something because this fetus is in trouble. Things like bradycardia, tachycardia, no or minimal variability, late decels, variable decels they keep happening, and this sinusoidal pattern. I'll show you what sinusoidal pattern looks like. This is right here. This is an up and down, undulating baseline, up and down, up and down. If you see this on a fetal heart rate pattern, this is a very ominous sign. It is a sign of asphyxia. This baby is not getting any oxygen, or all of its fetal red blood cells are being destroyed by the antibodies of that mom with an RH she's become sensitized. Excuse me. So if you see these things, that baby needs to be taken by C-section in an emergency situation, and we need to get that baby out. And that baby will have problems most likely afterwards. It will be in the NICU and hopefully won't have lifelong problems. So let's talk about this again. I just made this slide so you know all of these right here are not good fetal heart rate patterns. So what are the nursing interventions? This is really important. You'll get test questions on these priority nursing actions. So first thing we're going to do is identify the cause, what's happening. Hopefully we can figure out, and so we can do something about it. We're going to stop the Pitocin first off, as she has Pitocin running. We're going to change mom's position, give her O2 by face mask at 8 to 10 liters, give her IV fluids or pump up or give her a bolus. Prepare for maybe internal electronic fetal heart monitoring if we figure that this might not be a true, if it's a technological problem and not a true reading. And then we're going to prepare for a C-section delivery. We're going to call the HCP or healthcare provider. So let's talk about now non-pharmacological measures. These are measures that we want to do first before we offer any sort of pain management. And pain happens in labor for a couple of reasons. Physical pain happens in the first stage of labor. Remember, this is the dilation and effacement of the cervix because of the ischemia of the uterus during contractions. In the second stage of labor, pain also is happening because of the stretching of all these tissues and the compression of the pelvic structures. So it's ischemia added upon these things that cause more intense pain. And it can also be psychological. So a woman who's experienced chronic pain or had lots of pain in her life will experience pain differently than a woman who has not. So our own individual experience with pain is different from person to person, and it will be reflected in the labor process differently. So when we think about non-pharmacological measures for pain, we are thinking about this gate control theory, which really means that if we can block painful stimuli from passing this hypothetical gate or into the spinal cord, we're going to give it different kind of physical stimuli. It will block the pain signals from reaching the brain, because only one stimuli can go through that spinal cord at a time. So if we can block that painful stimulus, then we're going to hopefully decrease the pain or the pain that the mom is experiencing. Standard of care or best practices is to provide non-pharmacological before pushing any sort of pain, epidural, anything like that. So a nurse should offer any of these things before she goes ahead and has a patient, offers any sort of kind of pain meds. There's also breathing techniques and maternal positioning, and you can watch these in that maternal newborn videos in the comfort measures video. So first, this says support from a doula or a coach. They're so helpful in the labor process. They kind of help that woman get through that labor process, and I highly recommend them if any of you are thinking of becoming pregnant or having a baby. They're excellent birth companions. They are shown to increase women's self-esteem, decrease rate of oxytocin, use of epidurals, and the resulting C-section birth. So studies have shown that they actually can do all these things. This is water or therapy or hydrotherapy. It's just the warmth, and we can do this in the hospital. We don't give birth, from what I heard. I've heard some hospitals are, but from what I know where we work, we do not have water births. It provides smoothing stimulation to the nerves in the skin. They can lay in the water as long as they feel comfortable, and we want to make sure the water is not too hot though. It gives a really great sense of well-being. And I show a water birth in a moment. It's in there, so you can click on it whatever you want to, and it's such an amazing thing. And babies are not stimulated to take that first breath until they feel that drop in temperature. So a lot of students are concerned with babies taking that breath when they're in the water, when they're being delivered, but they deliver them pretty quickly up out of the water, and until they feel that sense of decrease in temperature, they do not take that first breath. So it's a pretty cool video. This is TENS. I'm sure you guys have heard of the transcutaneous electrical nerve stimulation. It sends these low-intensity electrical stimulation, and it's applied to T10 to L1, and it facilitates the release of endorphins, and as I said before, it blocks that painful stimuli from reaching the spinal cord. There's acupuncture. These needles are inserted into the skin at specific body points, and it can release endorphins. I think the problem with this is finding someone who will do this on a labor unit or during the birth process, but I've heard it works great. Acupressure is the same kind of thing, but you're pushing pressure points within the heels, on the backs, and on the hands of women. It can calm them. Therapeutic touch and massage. So this is effleurage. This is a kind of round motion that she's doing that the fetus actually likes too, because they can feel the gentle touch. And in the first stages of labor especially, it helps to decrease that painful stimuli. Or you can receive any kinds of these from a support person or a partner, and it's believed to increase levels of endorphins. Alright, I'm going to switch off the video and continue in a moment.